I was excited. Little did I know that I was over bleeding, excessive bleeding. But because of the excitement that now I am having my period, I didn't think it was an issue. My health itself, my kids, here I am fighting for my life, and then they're telling me that I have another condition. You know, a condition without a cure again. And to make matters worse, with endometriosis, they might remove the lesions surgically and then they come back.
So it is cyclical pain, very painful. When you ask about the pain and they describe it in different ways, some call it's like somebody who has a knife and has actually stabbed you with a knife. Somebody who has something hot, which is just cutting you, for example. And it is excruciating pain. We use what is called a pain score. Ask a patient, if you were to give this pain some marks out of 10, where 0 is completely no pain and you are okay, and you are doing your normal duties without any interference. Some of the patients say that the pain is a score 15 out of 10.
Welcome to another episode of Behind the Diagnosis. I am your host, Esther Ashira, and with me is our sign language interpreter, Judy Kihumba. Thank you to everyone who has been watching, subscribing, and sharing these powerful stories. And if you're joining us for the first time, karibu sana. You are now part of Behind the Diagnosis family. On the previous episode, we had Mercy Adoyo on the show as she shared her life with multiple sclerosis. Today, she's back with another deeply personal chapter of her journey. This time, living with endometriosis, a condition that affects millions of women but is often misunderstood or misdiagnosed.
Endometriosis, just what the name suggests. First of all, I may take you a little bit back to the female reproductive system. The female reproductive system has a womb, and it has tubes, and it also has ovaries. Now, when a woman has a period, it is because in the womb, there is what we call a lining, and that lining is called the endometrium. Now, during the process of the periods, the cycle, when the cycle starts, and the cycle starts with the first day of the period, when that cycle starts, there are messages which are sent from the brain to the ovaries to start developing or to wake up the eggs which are going to be used. Now, when it gets to around day 10, day 11, what we call ovulation occurs. What is ovulation? Ovulation is when an egg is released. In the meantime, as that egg is being prepared to be released, what we call a follicle is the casing or the housing of an egg. It produces a hormone, and that hormone affects the lining and starts preparing it for a baby to implant. So when ovulation occurs, the egg has been released and there is no intercourse, meaning that there is no fertilization of the egg. Now, that lining which was ready to accept a baby, to start growing, that lining has to come out. It has to be shed. And that is what we call a period now. Okay? Now, when we talk about endometriosis, that lining which comes out as a period gets implanted, gets fixated somewhere else outside the womb. And this can be very various places. Most commonly, it is found in the tubes, in the fallopian tubes. It can be on the ovaries. You remember we talked about the ovaries. Sometimes it can implant itself in the uterus itself, in the muscle of the uterus. And then it is called adenomyosis. And It can also be found, for example, if a patient has had a cesarean section, it can be on the cesarean section scar. If a patient has delivered vaginally, it can be found in what you call an episiotomy scar. That is a small cut we make to allow the baby to come out properly. It can be found on the cervix. The cervix is the opening into the womb. It can be found in the intestines as well, in the bladder, in the ureters. The ureters are the tubes where urine comes through from the kidneys.
Thank you, Doc. Hearing that definition gives us a better understanding that behind every diagnosis is a real story, a real journey, and real pain. Today, Mercy opens up about what endometriosis has put her through. And now, karibu sana Mercy.
Thank you so much.
Yes.
It's good to be back.
Yeah.
Thank you for having me again. And so my name is Mercy Adoyo Crystal, and I am a chef by profession and also a video editor. And today I am here to talk about endometriosis. So my journey with endometriosis has been there for a while. Let's say years, I say. So how it started, I was having my periods, but they were excruciating, painful, really painful. Like I couldn't function when I'm on my period. And then the bleeding was too much, and it lasted for more than 5 days. Like I could have my period for 2 weeks. So at first, I didn't know that was not right. So I just persevered, had painkillers when I'm having my periods, and skipped class and moved on with life, as if everything else was okay. And then with biology and education in school, you're told about your period, but nobody really goes into pain and what amount of pain is normal and what isn't. So most of us women, we grow up knowing that period pain is normal pain. Yes.
Wow. So you've mentioned about the excessive bleeding, but I would like to know that did it happen before or after MS?
Before.
Oh, before MS.
Yes.
So what is that one thing that made you realize that there is a problem?
Every time I could go to the hospital, they order blood tests, like full blood test. All the time my blood level was always low, And I'm feeding right, my diet is okay. So the question was, why is your blood always low? Always, like consistently. Every time I was going to the hospital, every time they did a full blood count, my blood was always low. So I ended up like having transfusions. Every time I'm having my period, I'm having blood transfusions. Yes.
So when did the diagnosis happen?
Last year.
Wow, how many years apart?
How many years? So many years, because I started my period when I was 18. Okay.
Mm-hmm.
So, by the way, backstory about that, I thought I was abnormal, in primary school, with other kids, my classmates, they have all started their period. I have not.
Wait, your first period
was when I was
18?
18. Yes.
Wow.
So all through school, I knew something was wrong with me, Like, why am I not having my period? But then we go to the hospital, they do tests, everything is fine. So the doctor is just telling my parents, we just have to wait. So like, for some people it's delays, others it comes early. So that was me having question marks. Am I really a girl? Like having periods is sort of like an identity for women. So I'm here, I'm in school, I'm seeing people like in biology are being taught about having pads and how to handle yourself when you're having your period. But then again, I'm not having my periods. And then it came. I was excited. Little did I know that I was over bleeding, excessive bleeding. Yeah. But because of the excitement that now I am having my period, I didn't think it was an issue.
And then you've never experienced it before.
Yes.
Yeah.
I have never experienced it before. And also, nobody talks about what amount is normal and what is not.
Yeah.
Like you're just told you're supposed to have your periods.
Monthly.
And nobody says that there is an extent that is not okay. So I continued living my life like that, having low blood counts and just moving on. And I didn't actually question it until the point whereby I started now having the transfusions. Yes. So last year, I fainted out of nowhere. I just passed out. So when I went to the hospital, I was rushed to the hospital. When I got there, my blood was 5. A normal person's blood count is over 10. Mine was 5. So the doctors were actually wondering, how did I get to the hospital? 1. And why am I losing blood so much? And that is where now they started investigating. Yes.
Wow. How long did the investigation take?
1, being a woman is hard. Very difficult. Because you have to validate your feelings. You have to over-express yourself just to be heard. The moment you go to the hospital, a doctor looks at you as a woman and assumes you're just stressed. They don't want to actually go further and investigate and find out what is actually wrong with this woman. But just at first glance, and considering the fact that I'm also a mother, they just assume, this one is stressed.
Yeah.
So just cut down on your stress, go on the pill, balance your hormones, and your bleeding will go back to normal. I did that for years. It never made any difference. When I was in school, my mother was actually told that if I have a child, everything will fall back into place. My bleeding will reduce. Everything will be perfect. I have 2 kids, and that is not true, because after even having my first kid, I expected that the change will happen, because come on, the doctor said that if I have a child, I will stop bleeding. But then I've had my first kid and I'm still bleeding. So I am wondering, when is this going to end? Yes.
Wow. And then you had a second child.
I had a second child. It did not make any difference.
Yeah. So now, investigation.
I am bleeding. I am having actually excessive bleeding. It was so much, it was so scary. Everywhere was blood. And now I am admitted in the hospital because I need transfusions. And when you get given a blood transfusion, it's like getting an organ transplant. They have to keep on monitoring you. So they monitor me, and I am receiving blood and I'm also losing others, So it is not stopping. They're giving you medication to stop the blood. It is not working, And it got to a point whereby my stomach started swelling, started becoming bigger. Now they're wondering, is this multiple sclerosis or what is going on? Because multiple sclerosis attacks the immune system, right? And nerves are all over the body. So it doesn't matter where. Multiple sclerosis can attack anywhere. So at first, what they concluded was that this is an MS flare. So multiple sclerosis is what is causing all this. But then multiple sclerosis is causing me to bleed. It does not add up at all. So we did CT scan, did an ultrasound, nothing conclusive. But then when we did the CT scan, it showed that I had masses on in my abdomen. And these masses were not really like, they couldn't tell what they were. So they decided to open me up and find out what are these masses and why is she still bleeding. Even when you have given her meds to stop the bleeding, she's still bleeding. So I went in for surgery. And that is where they found that I'm having endometriosis lesions, those masses.
So they found out during the
Surgery, yes.
Oh, wow.
Yeah.
With the uncertainties, how was that affecting you emotionally and even physically?
It was hard. One, I already have my MS, That is a whole fight by itself.
Yeah.
Now, I am looking for donors to donate blood.
Yeah.
Okay? And getting donors actually is not easy.
Yeah.
I get the donors. Having the blood transfusion itself is another hassle. Okay? Because at any point, you actually, by the way, your body can reject that blood. Yes. So I have to go through that. I'm also thinking about my health itself, my kids. Here I am fighting for my life. And then they're telling me that I have another condition. A condition without a cure again. And to make matters worse, with endometriosis, they might remove the lesions surgically and then they come back. So there is no sure bet that if we do surgery, you're okay.
Yeah.
Yes. And to make it worse, endometriosis lesions can occur anywhere in the body. Not only in the stomach, also in the lungs, also in the brain. And many people don't know about that, by the way. Many people just think endometriosis it's just a female thing and hormones, and that is actually not true. You might be on the pill, you might be menopausal, but still you have endometriosis. Nobody knows what causes it.
Yeah.
And there is no cure for it. So now what happens? You're put on a pill, yes, to balance your estrogen. If the masses are there, causing you discomfort, pain, like in my case, they are removed. But that doesn't guarantee that they will not come back. So you brace yourself, they might come back again, and you might need more surgery. Yes.
So how many surgeries have you done?
For endometriosis, I did 4.
So the first one that you did, then they discovered is endo.
Yes. And then another one to remove another mass.
Did it grow or
Yes.
first time they didn't see it?
It grew again. Yes. And right now I'm speaking to you, I have another one. I actually have 3 more.
In a span of?
6 months.
Wow.
Yes.
And how is the recovery after the surgery?
It is surgery. Surgery is non-guarantee. Nobody, like, you might go in and not come out, you know. And one thing about having surgery, anywhere in the body,
Yeah.
you know, once a cup is broken, no matter how much glue you put on it, it never comes back to the way it is. So that is exactly what happens with surgery.
Yeah.
Once someone opens you up, you can never be the same.
Yeah.
No matter how many fixing they do, you can never be the same. So that is my case. And then with abdominal surgery, you have stuff called adhesions, you know. And these adhesions, they might cause other lesions again. So having surgery, yes, it will help prolong your life, but also it will bring more problems. So what do? We just opt for the surgery to prolong your life and cross the other bridge when you get there. Yeah.
Yeah. Wow. And I'm just looking at you. There's MS and now there's endo. How has that affected your daily life?
For the past 2 weeks, I've not been able to feed. I'm actually feeding through IV fluids.
Like even today?
Yes. Even today when I was coming here, so I go the hospital in the morning, they gave me like 2 bags of fluids. I go throughout my day, and then in the evening I go back again, I get 2 more fluids. I've been vomiting bile. Yes. And my surgeon says that I need emergency surgery urgently. I need to get ready for another surgery.
For endo?
Yes. There is a lesion in my intestines. That is why I can't keep anything in. Every time I feed, it just comes out. Yes.
Wow. That's deep.
Yeah.
Yeah, that's deep.
Mm-hmm. So it is not easy. Like, it feels like I'm on this merry-go-round that never stops.
Yeah.
No. Like, you think you have recovered from one thing, another thing pops up.
Yeah.
You know?
Yeah.
Like, I have to deal with multiple sclerosis. I have to deal in endometriosis. You know, you're asking yourself, when will this stop?
Yeah.
When am I just going to get a breather and just pause, you know?
Yeah.
Yeah.
Are you in pain?
Yes, all the time.
So you are on constant medication for the pain?
Yes.
Like daily?
Mm-hmm.
For both MS and
Endometriosis, yes.
and endo?
Yes.
How hard is it for you?
It is difficult because, one, pain medication is very expensive. And I cannot survive without. I will actually, literally lose my mind if I do not take the pain meds. Because, one, my feet hurt a lot because of MS. I get this throbbing, pounding headaches because of MS. And now, endometriosis is affecting my gut, my stomach, my abdomen. So my insides also are always on fire. You know, feeding is a problem. And I need food to be able to move around, you know.
Yeah.
Since I'm taking a lot of medication, I need to have food. But now because of endometriosis, I cannot have food, you know.
Yeah.
So it is very frustrating. It feels like someone is constantly hitting me with a hammer. And it doesn't stop. So I can't even find the right words to explain it, but it is hard. Yeah.
I'm sorry.
Thank you.
I'm sorry for what you're going through. Yeah, and we continue trusting God that one day this will end.
Yeah, I hope
It will end. It will end well.
I really hope so.
Yeah, it will end well. And there are so many misconceptions surrounding endo.
Yeah.
So many. What can you tell people who, honestly speaking, don't understand endometriosis and have wrongly judged people suffering from the same condition? Just speak on their behalf.
Okay, 1. Having painful period is not normal. If you have to lie down all the time, take pain medication when you're on your period, something is wrong. Nobody should tell you that it is normal. It is not. Get checked. Be your own advocate. As women, people just assume that we are okay, we are strong. No. But it has gotten to a point whereby that should end.
Yeah.
Our voices need to be heard. So you're having pain on your periods, get checked and insist on it. Don't just sit there and wait. Like now, I waited for too long.
Yeah.
Maybe my situation could not have been this bad.
Yeah.
But I waited for too long, and right now I am suffering more than I should. Because I did not have this education. I did not have this sensitization of what endometriosis is. So right now I am suffering more than I should. And if I had the idea of knowing that the pain I am going through is not normal, I could have sought for help. I was in the hospital, yes, but I never voiced out, what about endometriosis? Check. So that is 1. Just because you're in menopause does not mean you not have endometriosis. Yes. And endometriosis can occur anywhere in your body, including your brain. So if you feel something is off, go and get checked. Yeah. Just because you're on the pill does not mean that endometriosis is gone.
Yeah.
Yes. And also, just because you're going to be told if you have kids, things are going to get better, that's a big lie. Yeah. A very big one.
Yeah. Yeah. I'm imagining someone who has such pain and they are 13.
Mm-hmm.
So will you tell that person to
have kids?
To have kids?
Yes.
Yeah. I think we just need a proper understanding of some of these conditions so that we don't just throw words.
Yeah.
Yeah. Because in the process, we are hurting others. Yeah. We are hurting others with our comments, and we need to make this world a better place so that even those ones who are suffering can be confident enough to seek help from you. Because if they can come and you tell them, you need to give birth, you will be fine.
Yeah.
Will they come back? Yeah. Because
it doesn't even make sense.
Yeah.
Why are you saying that a person's problems are going to end if they bring another person to this world, regardless of their age?
Yeah.
Having kids should be a choice, not a demand for survival.
Yeah.
Yeah.
I hear you. Wow. And I hope people are listening. And if there is someone who has been insensitive to someone else who's been unwell, and maybe you don't even know the condition that they have, please, let's make the world a better place. Yeah, and learn from Mercy's story and even others who are also going through the same thing. Thank you so much for coming again and shedding light on this. To be honest, this has been so deep. Even myself, I understand it better.
Yeah.
I just knew endo, but I didn't know the deep
definition.
Yeah, of it. Even just having a sit down with someone who's going through it, like I understand it on a different level now. Yeah, so thank you so much. We'll continue having these discussions so that everyone is aware.
Yeah, we should.
Yes.
It's about time that women are listened to.
Yeah.
It's about time that we have advocates. It's about time that we fight for ourselves.
Yeah.
Yeah.
Yeah. So let's keep voicing. Yes.
Yeah, we should.
So thank you. Thank you so much. We will give your number because I know you are a chef.
Yes.
And you offer such services. So if there is anyone who will want to reach out to you, just share your number.
My number is 0748 466 703.
Yeah.
0708 466 703.
Adoyo Jikoni.
Yes.
So thank you so much. If you have an event, baby showers, bridal showers, Adoyo lives in Utawala. So if you're in Utawala and its environs, and she also delivers. She does deliveries. So if you have an event, please reach out to Adoyo so that she can also support herself with this business. And from Mercy's story, it reminds us how invisible pain can be and how easily women's bodies are dismissed before they are heard. Stay with us.
Mercy has endometriosis and it has caused her lesions in her abdomen. The lesions are getting bigger, making it difficult to move and even feed. And right now, she needs to undergo an urgent surgery to remove the masses. We are therefore appealing to the general public to help raise funds to help cover the surgical expenses. You can reach her via M-Pesa number +254 748 466 703. That is +254 748 466 703. We welcome any kind of support. You can also send her an email via mercyadoyo22@gmail.com. We look forward to receiving your help.
Welcome back to Behind the Diagnosis. We've just had Mercy's powerful journey, and now it's time to get deeper insight from a specialist, a gynecologist with experience managing endometriosis.
My name is Dr. Kireki. I'm a consultant obstetrician and gynecologist, and as a fertility specialist. Apart from that, I teach at the University of Nairobi in the Department of Obstetrics and Gynecology. I'm a senior lecturer there. And I'm glad you've invited me to this show to talk about this very important and not talked about problem of endometriosis, which affects a large number of women, not only in Kenya, but worldwide. Endometriosis, just what the name suggests. First of all, I may take you a little bit back to the female reproductive system. The female reproductive system has a womb, and it has tubes, and it also has ovaries. Now, when a woman has a period, it is because in the womb, there is what we call a lining, and that lining is called the endometrium. Now, during the process of the periods, the cycle, when the cycle starts, and the cycle starts with the first day of the period, when that cycle starts, there are messages which are sent from the brain to the ovaries to start developing or to wake up the eggs which are going to be used. Now, when it gets to around day 10, day 11, what we call ovulation occurs. What is ovulation? Ovulation is when an egg is released. In the meantime, as that egg is being prepared to be released, what we call a follicle is the casing or the housing of an egg. It produces a hormone. And that hormone affects the lining and starts preparing it for a baby to implant. So when ovulation occurs, the egg has been released and there is no intercourse, meaning that there is no fertilization of the egg. Now, that lining which was ready to accept a baby, start growing, that lining has to come out. It has to be shed. And that is what we call a period now. Okay? Now, when we talk about endometriosis, that lining which comes out as a period gets implanted, gets fixated somewhere else outside the womb. And this can be very various places. Most commonly, it is found in the tubes, in the fallopian tubes. It can be on the ovaries. You remember we talked about the ovaries. Sometimes it can implant itself in the uterus itself, in the muscle of the uterus. And then it is called adenomyosis. And it can also be found, for example, if a patient has had a cesarean section, it can be on the cesarean section scar. If a patient has delivered vaginally, it can be found in what we call an episiotomy scar. That is a small cut we make to allow the baby to come out properly. It can be found on the cervix. The cervix is the opening into the womb. It can be found in the intestines as well, in the bladder, in the ureters. The ureters are the tubes where urine comes through from the kidneys. A good friend of mine, a consultant, actually told us about a very, very difficult case he had of a young lady who had bleeding, and she would bleed from the palms, she would bleed from the ears, and even from the eyes when she had her periods. And that is also endometriosis. So we don't understand how she would bleed from the ears, from the eyes. The mechanism, what you call pathophysiology, we just cannot understand it. Very rarely do we get it in other places. For example, in the chest, in the lungs. I've had a couple of patients who have had endometriosis of the hips, the hip joint and the shoulders, and also of the lung. One of them actually had a collapsed lung because of endometriosis. So it's a very complex, very enigmatic disease, and it affects about 10 to 15% of women, especially those ones who are trying to have a baby. So it affects infertility. You remember it embeds itself on the tubes, and when it embeds itself on the tubes, it affects the way the tubes function. And the tubes are supposed to be moving. So when ovulation occurs, it releases the egg. The egg is collected by the tube, and because of that movement, the egg is pushed into the tube such that it may be able to get fertilized by sperm. So if that doesn't happen, then the lining comes out or really has a period. Now, the interesting thing is that lining which is in the other places will work exactly the same way as in the lining which is in the womb. What does that mean? It means that when a cycle starts, it will be small, it will be thin, but then as the cycle progresses, because of the interplay of different hormones, that lining will start growing thick. So if it is, the lining is, let's say, on the intestines, it starts swelling. These patients start feeling bloated and start feeling pain. If that endometriosis is on the ureter, for example, it can block the ureters, so no urine will come out. If it is on the, let's say on the bladder, we'll have other symptoms as well. So and then once the period comes to an end, that lining also becomes thin, so the symptoms also start disappearing until the next time. Now, when we talk about diagnosis of endometriosis, the most important thing is the history, what the patient tells you. When a patient comes to me as a gynecologist, I need to take down a history. We start with when was the first period in life, and how are the periods? Are the periods regular? If they're regular, how often do they come? How long do they last? And then the most important question, are they heavy? Are they painful? Are there any clots? This gives us a very good idea about what is happening. When a patient comes and says, my periods are regular and they are painful, we want to know about the pain. Normally, periods should not be painful. Patients can have a bit of cramps, a little bit of lower abdominal pain, back pain, but not pain. And the pain for endometriosis is very, very characteristic. The patient will come and tell you, Dr. I have this pain, and this pain starts a few days before the period, even up to a week before the period starts. And then the pain reaches a crescendo because it's very painful when the period starts. And then after that, the pain starts, going down until it disappears. Sometimes it disappears completely. Sometimes it reduces, but it's somewhere in the background. And then until the next cycle. So it is cyclical pain, very painful. When you ask about the pain, and they describe it in different ways, some call it's like somebody who has a knife and has actually stabbed you with a knife. Somebody who has something hot, which is just cutting you, for example. And it is excruciating pain. We use what is called a pain score. Ask a patient, if you were to give this pain some marks out of 10, where 0 is completely no pain and you are okay, and you are doing your normal duties without any interference. Some of the patients say that the pain is a score 15 out of 10. So very painful. So the pain is there, and it is cyclical every month. The same story every month. This pain affects their quality of life. They cannot go to school, they cannot go to work, they cannot do the normal house duties, even conjugal duties. They can't have intercourse. And then we also ask, during intercourse, is there pain? Not all patients will have pain during intercourse. Some will say, yes, during deep penetration, there is pain. When they say that during deep penetration, there is pain, it means that endometriosis has affected other parts of what we call the pelvis, other organs. Do you have pain when you go for a short call? It means that the endometriosis could have affected the bladder. Do you have pain when they go for a long call, or is there blood on the stool? Then it would mean, if she says in the affirmative, then it means that endometriosis has actually affected the rectum and other organs. Sometimes the pain is difficult to describe, and it is all over. That would suggest that actually what we call the pelvic organs, the ovaries that I mentioned, the tubes, and the uterus itself, they are all stuck together, what we call a frozen pelvis. So that is where sometimes the patient cannot actually say, pinpoint and say this pain is exactly here, but it is, it is all over. So the history is very important, the medical and surgical history. If she's had any surgeries in the past, because you remember I mentioned that you may have endometriosis on surgical scar. So if she's had any surgeries in the past, if she's delivered, how many babies she has delivered, whether they were delivered normally, whether there were any complications, and so on and so forth. Then after that, we do an examination of the abdomen. A physical examination where we ask the patient to tell us which point is painful, which area is painful. We avoid that area. We start with the areas which are less painful. And then when we get to the area which is painful, as we are doing this, we are looking at the patient's face, because when you touch, they say, apodactaria pop. And then you will actually see, know that there is a problem there. So take a history, a physical examination. And the physical examination also entails a vaginal examination, where we examine the patient, vaginally using our fingers. And at that time, there are some places you can touch. For example, the cervix, and the patient will feel pain, or even on the sides when you touch, the ovaries, where the ovaries are supposed to be located. There is what we call the pouch of Douglas. That can also be filled with the endometriosis or endometrioma for that matter, and this will cause pain. Then the next step is to do a scan, an ultrasound scan. The ultrasound scan can be done in two ways. It can either be done through the vagina, what we call transvaginal ultrasound scan, or transabdominal, where a patient is told to drink a lot of water, and when she feels that she can't hold the urine any longer is when we go and have a look at what is happening. That is another way of diagnosing. Sometimes we send these patients for MRI. The MRI is much more specific, and it can also show whether the structures, the other organs are stuck in the pelvis or even in the abdomen. Now, something else which used to be used some time ago is what we call laparoscopy, diagnostic laparoscopy. What does that mean? It means that we admit this patient to hospital, we take her to theater, we give her anesthesia, and then we make a small hole around the belly button and maybe 2 or 3 other small holes on the side. We go in with a camera. And then as the camera goes in, we'll be looking at a screen. And then this screen we will see, because the camera shows us what is happening in what we call the pelvis. And when it is endometriosis, sometimes it is so obvious. You can actually see it. Everything is stuck together, for example. And that means that this endometriosis is actually advanced. Or sometimes we may see only small areas where the tissues have changed color, and we can take samples for them from there for diagnosis. Now, because laparoscopy is not everywhere, especially in Africa, and especially in Kenya for that matter, you may not find an expert, in the machinery, as we say. So internationally, what has been decided is that the most important thing is the history. If you're able to do an ultrasound scan, that is good, but we can give this patient some medication which is specific for endometriosis if there is a change in the symptoms. And she takes it for 3 months. If there is a change in the symptoms, you remember she could have said that the pain score is 15 out of 10. And if the pain score comes to, let's say, 3 out of 10, it means that we have really helped her, and that actually this medication has actually helped her. So we are able to actually diagnose endometriosis indirectly, whereas by doing laparoscopy, diagnostic laparoscopy is that direct, in that we have to see that there is endometriosis, and then we make a diagnosis. Now, we see patients in different age groups with symptoms of endometriosis. A colleague of mine actually did a study in one of the secondary schools, and he found out that about 25 to 30% of the girls in that school had symptoms of endometriosis. And that is a school of about 800 to 1,000 students. So endometriosis is here with us. We live with it. Now, does it affect mature women? They are not older women, they're just mature women. Once a lady starts having her periods, it means that she can actually get pregnant. So she's in that reproductive period. So endometriosis affects women in the reproductive period. But when they get to the menopause, when they can no longer be able to have babies naturally using their own eggs, then we actually very, very rarely see cases of endometriosis, simply because endometriosis actually feeds on the hormones that are produced by the ovary, that is estrogen. And estrogen is what makes women be women. So when women get to that perimenopause or the menopause, the ovaries don't produce as much of that hormone as normal or as it was before. So the chances of getting endometriosis is very, very low. So should patients be afraid if they start their periods late? For example, Adoyo started her periods when she was 18 years, and most of the time this can actually be a point of concern. What is happening to this lady who hasn't started her period, and her peers, they're using pads and, they're feeling very feminine for that matter. No, they shouldn't be worried, because all of us have a different, we are created differently, our bodies respond differently, and there is what we call the endocrine system is activated, at different times. That is number one. Number two, the foods that we eat can have an effect on how our bodies behave and how we start our periods. For example, chicken, or even cows, they're given a lot of hormones, and some of these hormones will actually find their way into our food, our food chain, and we also partake of them. That's why you find sometimes very young girls, maybe 10, starting to have periods, which is a bit early. But there are others who may start a little bit late. And there are some who will not have periods completely as well, but that is something completely different. And especially these are the ones, for example, who have what we call Müllerian anomalies, whereby they may not have a womb, or the womb is very tiny, and that it may not respond to the hormones which are circulating in the body. Now, something else which is very important is what we call a differential diagnosis. You see, we mentioned the pain. That is one of the biggest red flag. The cyclicity of that pain, that it comes every month. There could be also other diseases which can mimic or can have similar symptoms to endometriosis, and that is, one of them is called adenomyosis. Adenomyosis is basically the endometriosis, but this time it is not outside. This time it is in the muscle of the womb itself. It has invaded the muscle of the womb. Now, the patient will have exactly the same pain. It will be cyclical, it will be painful, and the pain score will be also out of this world. But then the other thing is that her periods will also be very heavy as well. Whereas in endometriosis, the periods can be normal. The flow can be normal, but in adenomyosis, they can be quite heavy. So that is the sort of the distinguishing factor. And then apart from that, the pain, the feeling bloated can also be because of other things. Can also be because of, let's say, there is a growth on the ovary, what we call a cyst. There are other cysts. There are cysts which are endometriomas, which are part of the cysts as well, where you have old blood in them. A cyst is basically a collection of blood, a structure which has something in it. It can be fresh blood, it can be old blood, it can be clear fluid, it can be mucus-like. Sometimes you may have teeth inside there with hair and oil, and so on and so forth. So there are different types of cysts, and these can give symptoms which can be similar to endometriosis, but there is a point of departure is the cyclicity of the pain and the intensity of the pain. Now, is there a possibility that a patient can have several of these diseases at the same time? For example, can a patient have endometriosis and adenomyosis at the same time? Yes, there is such a possibility. And it's also possible that you may have endometriosis and adenomyosis and fibroids as well. And you may have endometriosis, adenomyosis, fibroids, and you have infertility as well. So unfortunately, these combinations are there. And that becomes very complex to manage such patients. Now, once we have listened to the history, we have examined the patient, we have done the scan, and we basically have all this information. The issue now is, what do we do with this patient? Sometimes these patients have had these symptoms for many years. There was a study which was done, I think, in Europe some time ago, and they have a much better organized system than we do have. And it was noted that from the time the patients have symptoms until there is a definitive diagnosis of endometriosis took almost 10 years to 11 years. And that is in Europe, where they have a very organized, healthcare system. In this part of the world where our healthcare system is almost not there, unfortunately. So patients will live with these symptoms, and most of them, unfortunately, may never get diagnosed at all. And then when they die, in some places, itasema alirogwa, uchawi, and so on. So we put a label. If we can't explain something, we'll put a label, of urogi and uchawi and so on. So when we have this diagnosis of endometriosis, there are several options of management. Some of them we can actually divide them into two, into conservative management and into surgical management. Sometimes we use both of them, one after the other. What decides we are going to use conservative management or surgical management? The conservative management is if the pain, because this is the worst thing in endometriosis. If the pain is manageable. So when the pain is manageable, we normally start with very simple, painkillers, paracetamol, Panadol, ibuprofen, and so on. But unfortunately, most of the time we find the patients start with these very straightforward painkillers, but then it reaches a place whereby they don't work. So we have to graduate to other stronger painkillers, whether orally or sometimes through the veins. And if that doesn't work, now we have to come back to the drawing board. There are other medications, hormones, which we can use. And the hormones, the way the hormones work, especially combined, we have what you call combined oral contraceptive pills, is that they stop the normal cycle, reproductive cycle. They stop the ovaries from working, and because they stop the ovaries from working, remember we talked about endometriosis feeds on a hormone called estrogen. So if that estrogen is not there, so the endometriosis will not grow. So hormones are one of the medications that we use for conservative management. There are patches as well, which are contraceptive as well, and so on. Then we have injections, but these injections have side effects. The injections which stop a part of the brain called the pituitary gland from communicating with the ovaries so that the ovaries can release, estrogen. These injections block that communication, and unfortunately, this is called chemical menopause, because once the ovaries are not working, and this is a young lady, she will have, symptoms. For example, you start having night sweats, hot flashes, palpitations of the heart, insomnia, not being able to sleep well, mood swings especially. So these are medications which we use very judiciously, very carefully, and it's not on everybody, and we don't use them as what you call the first line. These ones come much later. If all these don't work, or they have worked and they have stopped working, then we can actually consider taking this patient to theater and doing surgery. The best option in terms of surgery is laparoscopic surgery. We can also do open surgery as well. But laparoscopic surgery, the biggest advantage of laparoscopic surgery is that, number one, when you put that camera inside the abdomen, we can actually magnify what we are seeing, making it a lot easier to operate on it, number one. Number two, we can reach some places which sometimes the fingers cannot be able to reach, which we can be able to reach, during laparoscopy. The other better even method of operating is called robotic surgery, where we have a patient lying on the bed and the surgeon is actually in a console a few feet away. So it's like playing, what do you call them? Playing games, yes. So he is there, he has a screen and he controls the instruments using his fingers. So the surgeon is not cutting, the surgeon is basically manipulating the instruments which are in the abdomen. This is the best. Ideally, this is what we should be doing. Why? Because in robotic surgery, we have different arms, so we can insert them into the abdomen, and they will help us to get to some very complicated, very places where even sometimes the laparoscopic surgery is difficult to reach. But Paula Sana, we don't have robotic surgery in Kenya, but we hope. Like our colleague alikuwa ni Lupita Nyong'o who said our dreams are valid. Our dreams are valid. Tutaileta robotic surgery one day, God willing. So let's say we have done this surgery and we have removed whatever we can be able to see. Does that mean that is the end of the story for this patient with endometriosis? Sometimes no. Sometimes we may need to go back in 2 times, 3 times, 4 times. Adoyo has had 4 surgeries. She's going in for a 5th surgery. Why do patients sometimes need to go back? Because when we do this surgery, we remove what is called macroscopic areas, what we can see of the disease. But then there are microscopic areas which we can't see. So if she's in the reproductive period, we have removed what we can be able to see. We have given her medications, but there are those areas which we couldn't be able to see with our naked eyes. So with, again, going back to the ovaries, they're producing estrogen, the same reproductive cycle. Those microscopic areas which we are not able to see will also start now growing again. And then remember that every surgery, subsequent surgery, becomes more complicated, and then the healing process will take longer, and so on. So unfortunately, that is why some patients we may need to go back in several times in order to be able to help them. Now, remember what I said right at the beginning of this discussion was that one of the singular outstanding symptom is pain, period pain. And then unfortunately, there are some areas or some people have actually normalized that pain and saying, even us, for example, we get mature ladies telling younger ladies, even us, when we were growing up, we had this pain. So stick to it, it will be okay. Get a baby and the pain will disappear, that sort of thing. Now, number one, period pain, as I said, periods should not be painful. And if they are painful and excruciatingly painful, affecting the quality of life, that already is a problem. That is pathology. That is an abnormality. So we cannot normalize this pain and say, I grew up with this pain. When you get a baby, the pain will go away. But who says he wants to have a baby? Or who says she wants to have a baby at that particular time? Okay, so let us not normalize pain. So for those ones who may be having pain, or sometimes they may be having very heavy periods. Very heavy periods could be because of other reasons as well. Could be because of fibroids, for example. Could be because of what we call endometrial polyps, hormonal imbalance, and so on and so forth. And when you talk about very heavy periods, somebody will ask, how do I know that these are heavy periods? When you talk to patients, We talk about how many pads do you use in a day. Some of them we tell you, Daktari, I use the maxi ones. Come on, gynecologists, we know what types of pads. Natumia maxi, natumia na tampon, and then I also use a towel. And the period still leaks. So those are excessive amounts of blood that these patients are losing. So that is abnormal. They need to come for a consultation. We do diagnostic tests. We see where the problem is and to help them. The issue of having a baby, that endopartum toto, and the pain will disappear. The truth is that once a lady gets pregnant, the ovaries stop working. They are switched off for that time. And if there was endometriosis, because the ovaries are not producing estrogen, however, the placenta produces a bit of estrogen, but that's a different story altogether. So there will be note that being fed, the endometriosis is not being fed by the estrogen. So whatever spots which were there will actually die off. Okay. Now, a question will be now, what happens with the next period or with the next cycle? Once a woman delivers and she's breastfeeding, and if the breastfeeding is on a regular basis, there is no menstrual cycle. Again, if there's no menstrual cycle, whichever endometriosis was there, we not get any food in terms of estrogen. So that is why they say endopartum toto, uchungu itafanya nini? Itapotea. And it actually disappears. But again, you can't tell a 12-year, 13-year-old, 14-year-old when they get a baby and the pain will disappear. We have a problem with teenage pregnancies, so we can't also tell them, go and start having baby. They have no business having babies, at 13, 14, or 15. I mean, sort yourself out first before you start having a baby. So the most important thing is that we know what to do, and we know where to get this help. So these patients who have these challenges can actually come to us, and we'll be able to help them. So there is hope. Let them not die. Let them not have this problem to themselves, and because of the stigma, because of the painful periods, and so on and so forth. And then again, at this point, I would also like to advise employers as well, because patients will have this. It's a medical problem. So if a patient misses work 2-3 days in a month because she can't even get out of bed because of that pain, and then unfortunately, you'll find some men bosses will be more understanding than women. Women anasema, kwani period wewe tu ndio na uchungu? Watu wanakuta wana periods na wana uchungu. What makes you so special? That sort of thing. But I think that is a very bad way. It's not an empathic way of approaching this, because these patients have real challenges, health challenges. We should be sympathetic, and we should be supportive, and we should be helpful. Okay, finally, I want to thank you for inviting me to the show to talk about this problem which affects a large number of our women. And I want to tell them this, that there is hope. With those heavy, painful periods, there is hope. With pain for endometriosis pain, there is hope. With infertility, because infertility can be secondary to the heavy painful periods and also infertility, there is hope. And I am a fertility specialist, and I help couples who have challenges getting pregnant. And then lastly, you can always find me. My office is located at 5th Avenue offices, and this is along Ngong Road, 5th Avenue offices, on the 3rd floor, room 314. And the number to the office is a very easy number to remember: 0780 170 170. 0780 170 170. Karibuni.
To Mercy, your courage is an inspiration to many. Thank you for helping us understand what living with endo really means. and please keep that hope alive. To everyone watching, if you know someone whose story needs to be heard, reach out to us on 0701 300 799. I am Esther Ashira, and with me is our sign language interpreter, Judy Kihumba. Thank you for being part of Behind the Diagnosis. And remember to like, subscribe, and share so that more lives can be reached with truth and hope. As always, every story matters and every voice deserves to be heard.